Hi everyone, this video is supplement to the first H's and T's thrombosis pulmonary embolism video, so please watch that video first, then come back for some additional information on PEs in ACLS starting right now. So first, what other types of patients are prone to develop pulmonary embolism? Tragically, we see this in pregnancy. And in fact, it's the #1 leading killer in pregnancy. Right after the birth, mom could develop a pulmonary embolism. Now, why does this happen? We all know that by the time the pregnancy reaches term, 40 weeks, mom's circulating volume has increased by about 50%. And most of this is plasma. And that's where the coagulation factors live. So by the time we get to term, mom is hypercoagulopathic. She's a walking blood clot. This is a good thing. This is by design because it's supposed to help offset the bleeding associated with childbirth. Quite simply, she has more clotting ability so mom doesn't bleed to death during childbirth. But we also have all these increased platelets. And before the birth, if mom is laying flat, baby's pressing on the low pressure venous system, it starts to restrict blood flow, clots can form. So pregnancy is at a higher risk for developing a pulmonary embolism. Next, let's look at some additional physiology that occurs during a pulmonary embolism. Now, the pulmonary embolism usually occurs because a clot formed in the venous system, traveled to the right atrium, to the right ventricle, through the pulmonary artery into the lungs. Now, the blood flow through that part of the lung has now been restricted, which means that part of the lung can no longer perfuse. Enter the hypoxic pulmonary vasoconstrictive response. And because that area of the lung infected is no longer perfusing, the vasculature around it constricts down in an attempt to shunt blood to other areas of the heart so it can oxygenate. So you can have a substantial amount of vasoconstriction occurring within this lung. And that constriction creates a back pressure. So that back pressure is coming back through the pulmonary artery, right back into the right ventricle. And that right ventricle becomes distended because of that pressure. It becomes distended and it increases wall tension of the myocardium. Now remember, those coronary vessels come from the outside and have to penetrate through that myocardium to perfuse the heart. But because we have this increased wall tension, because of the pressure within the right ventricle, coronary perfusion is reduced, so the heart can become ischemic. Furthermore, as the right ventricle increases in size, it begins to push over on the ventricular septum and begins to impinge in the left ventricle. This reduces blood flow into the left ventricle, reduces cardiac output, and subsequent coronary perfusion, so the heart is becoming more and more ischemic. This is an obstructive problem. The pulmonary embolism is causing an obstructive heart failure. The treatment? We got to remove that blood clot. That's it. We have to remove that embolism. Either they're going to surgery for a surgical embolectomy, we could still try a mechanical embolectomy with a catheter, but we got to get that clot out. Here's the rub. If we can't get the clot out, we got to go around it. And that's where ECMO comes in, extracorporeal membrane oxygenation. And there's two types. There's venous to venous ECMO, which was really designed to bypass the lungs. At this point, the ECMO machine becomes a pair of extra lungs, period. There's also AV, arterial to venous ECMO, where we can take the blood out, just like in VV, clean it, oxygenate it. Now we can return it to the heart under pressure and give this patient hemodynamic support. Now this patient here, arrested actually after surgery, and was placed on ECMO very quickly. She developed a pulmonary embolism, but was quickly placed on ECMO. Then we were called to transport her and fly her elsewhere for specialized care and continuum of care. I'm happy to report that this patient made a full recovery, which was awesome. But that probably may not have happened had ECMO not been available right there on the spot. So probably the best therapy is if we know we have a suspected pulmonary embolism, we begin the treatment and we transfer this patient to ECMO therapy as quickly as possible. So this has been just a quick supplement to the original H's and T's pulmonary embolism video. I'm Mark, thanks for watching. See you in the next video. Lung, 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 lung. Okay, so those are different timings. We got to clip that into one of the bits. See you, homie.